if they're staying in this externally rotated position, then what they're going to try to do is turn their pelvis. They're going to try to anteriorly orient their pelvis to create the downforce, which would be the internal rotation.
Good morning. Happy Monday. I have Neuro Coffee in hand and it is perfect. All right. So we just wrapped up the intensive 13 yesterday. It was outstanding. You should have been there. We did a couple things that we've never done before. We did this big expansion on the Camperini deadlift for those of you that like to play around with that exercise. We broke down the cross connects and all that kind of stuff, in addition to revising and evolving the model as we always do during these intensives. So I had a great time. The guys are working hard on their intensive 14 preparation right now. So again, looking forward to that next month. Okay. Digging into, oh, wait a minute, quick housekeeping note. IFS University, we have a Q&A today at 1 p.m. Eastern Standard Time. If you're not on IFS University, go to ifsuniversity.com, get signed up, and please join us at 1 p.m. Okay, now, today's Q&A is with Sam. So Sam's a coach, and he had a series of clients that all kind of came in with the same physical structure, same representation, and they all ended up with anterior hip pain symptoms during some squatting. And so we kind of broke that down a little bit for Sam. We talked a little bit about solutions. I wanted to give you a little bit more of that. So what I did is I took the 3 hip impingements, 3 solutions video, tacked a chunk of that on to the end of today's video. So today's a little bit of a longer one. It's going to be 20 some minutes for you, but you'll get a really good representation of what you're looking at when you have those people that, especially with squatting, end up with anterior hip pain. And because it can be a big deal and it can be a lot of interference, you have to rule out structure. So just be really, really careful as you progress those fine folks. If you would like to participate in a 15-minute consultation, go to askbillhartman@gmail.com, askbillhartman@gmail.com. Put 15-minute consultation in the subject line, and we will arrange that at our mutual convenience. Everybody have an outstanding Monday, and I will see you tomorrow.
All right, Sam, go ahead. What's your question?
Okay, so in the past 3 weeks, I've had 3 or 4 clients all complain about hip impingement in the same exact spot. It's on the front side of the left hip, and they all complain about it's just pain during flexion, and then during abduction also, and then also during squatting. So basically, and me and my manager, we came to the conclusion that it could be a possible labrum issue through some 2 or 3 tests, and I was just wondering could it be a programming issue on my part, basically just putting them through in positions that could be causing this issue, or is it how else would you go about determining what this could possibly be? Because I've had 3 or 4 people in the last 2 or 3 weeks all complain of the same thing.
Well, so is it showing up before they get to you, or is it something that's happening while you're working with them?
It showed up basically it would be right after, while I'm working with them. Yes, it'd be right after their initial first set of squats. They would compare.
So they didn't have the symptom prior to?
No.
Okay. All right. So number one, you need to protect them. So if this is something that's new, that's its first representation while they're working with you, then, and again, it could be any number of things. You may still need to rule out a structural issue. Okay, but now you have to take into consideration what might be going on. Okay, so under the circumstances where if you're closing the space in the front of the hip, so you're bending the hip and they're getting symptoms under those circumstances, that space is closing too fast. So under those circumstances, typically what's going to be happening is that you've got some posterior musculature that is concentrically oriented. So you're getting a compressive strategy on the backside of the hip. So as they bend the hip up and you're bringing it up into a straight line, which you mentioned flexion. So if we're using that as the representation of where you're actually measuring this, then you're just closing that space is closing too soon. Okay. Which again, if you notice that you're playing with their foot position, does it change the symptom?
Well, yeah, I tried to have them go wider and closer. Not really. No, it kind of like they kept it stayed the same even during that.
Okay, then you may also have the anterior orientation that goes with it. And so under those circumstances, then those are going to be the people that you want to avoid with that deeper hip flexion. Okay, because you don't have enough space there to move them into it. So number one, don't do stuff that hurts. Okay, first rule, right? Secondly, you're going to have to create some space. So again, if you have to reorient the pelvis so it captures some of that posterior orientation that they might be missing, you do that first. All right. You need to create some external rotation space. So when you have somebody that orients forward, their external rotation moves away from midline. So it moves out to the side. To bring their leg back in, whether you actually create space, you have to move the pelvis back first. Then you might have to recapture an early representation of propulsion. So this is where you have external rotation available to you. So I don't know if you guys do direct measures of hips and things?
What do you mean by direct measures? Sorry.
Like you actually move somebody into hip flexion, like you check it, or no?
No, not really. No.
Okay, so you have to have a representation of it. So again, their ability to sit comfortably might be sufficient, or to be able to move their knees towards each other as they're sitting to sort of capture that position. So you need to retest to make sure that you're not reinforcing the anterior compression of the hip. Okay, so again, you might have to bring the pelvis backwards. So under those circumstances, you're going to use some form of activity where you're changing the orientation of the pelvis. Okay, and then you have to be able to turn into that hip. Okay, so that is superimposing internal rotation on top of the external rotation. So you bring the pelvis back, and then you teach them how to turn into that front leg. But first things first, just make sure that you're eliminating all activities that would reproduce the symptoms. If the symptoms persist, then you may need to actually send them to a health practitioner for evaluation to rule out any structural abnormalities, because they do happen. Some people have them and never know until they do something.
Okay. So you said bring the pelvis back into a more posterior orientation. So is that essentially just like cueing them to basically rotate that and have that and sit that back more? Or?
Possibly yes, but under many circumstances you might have to do something that's kind of floor based, put them in some form of like a hook lying activity to teach them to bring the pelvis back. Chances are, if they've got an anterior orientation, so that's the whole pelvis, so that's the sacrum and the innominate bone moving together, and you might need to be able to, you might have to restore relative motions first. So under those circumstances, you have to reduce the anterior orientation. Otherwise, you don't get the relative motions back between the two bones. So again, it might be something in hook lying. It might be something that would be considered like lower glute or hamstring oriented kind of a thing, right? Sometimes you can do it in like a shallow staggered stance. If you put them in like a right foot forward, left foot back with a cable chop towards the back leg, you can actually create the early representation of the pelvis under those circumstances. And then that brings the pelvis back, and it also starts to superimpose the internal rotation on top of it. So, and it doesn't compromise the hip position under those circumstances, because you're not compressing the front side of that hip. You're in sort of like a very shallow, lowered center of gravity versus a deeper squat where they're going to have symptoms.
Mm-hmm.
Does that make sense?
Yeah, that does make sense. Okay.
Yeah.
So essentially just take them out of areas where they're having pain, first of all, and then bring them into more exercises that would bring them into more posterior. So they
Right. So you've heard me talk about cross connects and arm bars and rolling and things like that. So
Yeah.
all of those activities can be useful under those circumstances. Right.
Okay.
But again, you got to be careful that, again, don't create the irritation.
Right.
Right.
Okay. Yep. That makes sense.
I got you in the right direction.
Yeah. I didn't know where to go. Basically, I just tried a few different things, but yeah, I have a much better idea where.
Think about that. You think about the musculature on the backside of the pelvis that attaches to the ischial tuberosities, like hamstrings, lower glutes, those activities that are going to bring the pelvis backwards. Now, keep in mind, it is not squeezing the glutes together like people tend to do when they posteriorly orient their pelvis. So you got to make sure that you avoid that, okay? Because that is literally creating the compressive strategy that got you there in the first place.
Right. Yeah, that makes sense. Yeah.
Okay. And then, if you need to progressively lower them down, you can use your box height, right? Start at a higher box. Make sure you're avoiding the positions that are again offending.
Okay. Yeah, I like that.
Anything else?
I guess that was the main thing. I just had like 4 or 5 people that had, or sorry, 4 people that happened to. So I was just trying to think of different strategies that would go about in fixing that. But
Right.
no, pretty much it. Yeah.
Yeah. So a lot of the representations that you're going to see are the people that need to squat with their legs out wider, or they toe out excessively, right? Or you'll see them do a split squat and their knee deviates away from midline, or they roll to the outside of their foot. Those are going to be the people that are going to be predisposed to this thing. So what they're trying to do is they're trying to create a space in the front of their hip so they can lower themselves down into those situations. Okay.
Yeah, I mean, I noticed all of them had like that kind of narrow infrasternal angles, and they all had like the kind of like the wider hips along with that. So I don't know if that all had something to do structural wise. Or...
Yeah, it's somewhat, because the narrow ISAs are going to be biased more towards an externally rotated representation. Okay, which again, so as you lower yourself down into a squat or into a split squat, you need to move towards internal rotation. If they're staying in this externally rotated position, then what they're going to try to do is turn their pelvis. They're going to try to anteriorly orient their pelvis to create the down force, which would be the internal rotation. Right. So again, you have to create the expansion on the backside of the pelvis, which is the external rotation. So bring the pelvis back, create the counter nutation in the sacrum, ER representation in the innominate, and then you can start to superimpose the internal rotation on top of that. And like I said, that's why I kind of like the staggered stance stuff, because it doesn't lower them into the offending position, and it starts to create this representation of the early propulsion, which is what you actually need. So you need an ER in the pelvis, yes, but you need to bring them back to an early representation. Chances are, if they're having this symptom, they're still ER'd, but because of the pelvic position, you're getting a late propulsive representation, which is not going to give them the same amount of space. Okay.
Mm-hmm. That makes sense.
Any other questions?
That's it, sir.
Awesome. Okay. If you have any other questions, just let me know. Okay.
All right. Thanks a lot.
All right, man. Have a great day.
And this comes from Chris. Chris and I were having a discussion, and he says, I really appreciate the 3 impingements, 3 strategies, 3 solutions for the shoulder that you did. Would there be something similar going on in the hip regarding impingement? And if so, could you do the same thing for the hip that you did for the shoulder? Thanks. So, Chris, you're not going to believe this, but this hip impingement thing is exactly like the impingements in the shoulder. We just have to look at it from the appropriate perspective. And so when we did the shoulder thing, we talked about the 3 classic impingement tests that we would use, and then we gave solutions. And so what I'm going to do is I'm going to compare these hip representations directly to the shoulder representations, and you'll kind of see how this all plays out. And so we'll talk about like what interferes and what doesn't, and then we'll give some exercise progression. So there'll be a fair number of exercise examples in this, I think, as we go through this. So let's break this down a little bit. So we had in the shoulder, we did the Hawkins-Kennedy, we did a Neers test, and then we did like the classic painful arc. And so the way that these are going to be represented in the hip is going to be through our hip flexion, traditional hip flexion measures, and through our abduction measures. And so all of these are going to be representative of external rotation measures, but the interference is going to be internal rotation in every case. And so we're going to have a situation where, because of the orientation, we're going to give up some ER. We're going to have an overemphasis on the IR, and that's what causes the compressive strategies that can actually result in pain, or as we would say, a diagnosis of impingement. And so let's look at the Hawkins-Kennedy test first. So if we look at the shoulder, we're going to see that it's internal rotation at about 90 degrees of traditional flexion, and so that would be representative of internal rotation superimposed on a little bit of hip flexion at 90 degrees in the hip. And so there's our commonality. But what we got as far as findings are concerned is this is going to be a situation where we've got posterior lower compression. So we're going to lose early hip flexion because hip external rotation under these circumstances would be in this early stage of hip flexion. But the problem is we got to think about this in 4D. Remember, it's not an arc. Okay, so if I'm coming up this way, that would normally be external rotation. The problem is under these circumstances with the posterior lower compression, external rotation is way out there. And so external rotation goes this way, not straight up in front. If I go straight up in front, I'm moving into internal rotation, which means I'm going to max out my internal rotation too soon. And then under those circumstances, I keep driving harder internal rotation, and I bang into it right at 90 degrees. And so there's my compressive strategy. So what we have here is an outlet, a pelvic outlet that wants to remain narrow, wants to remain eccentrically oriented. So as far as interference goes, we want to eliminate all this bilateral hip extension kind of stuff because, again, ER is way out there. We want to restore it here in the middle. So this means that those of you who are just fond of your hip thrust because you wanted glute development, let's get off of that train right now. No low cable pull throughs, and then your reverse hypers are also going to be off the table under those circumstances. So from an exercise standpoint, we want to reorient the pelvis, and we're going to stick with unilateral activities. And so you know how I love my cross connects, and so we're going to use a cross connect, but I want you to pay attention to something very, very important here, and this is going to be your foot contacts. And so if we're doing a supine cross connect, we want to make sure that we're capturing the foot position on the wall. This is first met head on the ground, so to speak. The ground is now the wall, and we got that medial heel contact. We want to maintain that throughout because this is where we're starting to initiate internal rotation from an externally rotated position. And this is what we have to recapture when we're talking about reorienting the pelvis. And then we want to move to something that's a little bit more hip flexion, so we can move into a hook lying situation. We still want to induce some internal rotation, so we're going to put something between your knees to hang on to that internal rotation, but from a position of external rotation first. Once we can capture 90 degrees of hip flexion, we got a lot of cool stuff that we can do. So we can start some rolling activities, and we're going to teach you how to roll into the affected side, and we're going to drive propulsive strategies on the opposing side. As far as some gym related stuff, we want to use, we can use our box squat, but we're going to use a touch and go. So remember, we've got an eccentrically oriented pelvic diaphragm. We want to concentrically orient that sucker. And so if I unload on the box, I'm going to get some of that eccentric orientation and some yielding action that I don't want. I can then, again, because I have 90 degrees of hip flexion, I can start to turn into that side, so I can start to capture a true internal rotation at the right point. And so that's going to be my Jefferson split squat's going to become real handy because I'm going to start from that ER orientation, and I'm going to hang on to ER orientation as I start to superimpose the normal IR on top of it. We could use split stance activities that are using like an ipsilateral cable load. So if I was doing a left foot forward split squat, I could put the cable in the left hand, hold that left side back, and again, I'm going to move from an ER position to an IR position under those normal circumstances. 3D straps that are going to push you into the original orientation and teach you how to resist and move into it. Another great opportunity to recapture these positions. Let's move on to the next one. So we talked about the near, which is impingement above 120 degrees in the shoulder. So we're going to represent this kind of the same way. So this is going to be the end range hip flexion measure where we're going to start to feel that impingement. And so what we have here is a situation where what I need under those circumstances to have a normal hip flexion and range is that I have to have a lumbar spine that can turn towards that measurement side of the hip, so the ipsilateral side. If a spine can't turn that way, then I'm going to end up with that end range impingement. So this is going to be a wide ISA that can't close. And so now I have a concentrically oriented pelvic diaphragm. So right away, my interference is going to be hinging activities. So I got to minimize hinging activities. The exception might be a higher box squat with a delay strategy on the box, so I can get the outlet to eccentrically orient and capture some yielding action. So that might be the exception to that. We do have 90 degrees available to us, so we can do all sorts of cool things. So we're going to start in a staggered chopping action. We want to reduce the effects of gravity, but we also want to start to be able to turn the spine towards the affected side. And so in the staggered stance, we're not compressing that hip, and we can start to encourage the turn of the sacrum, turn of the spine in that direction. This is where we're going to start to use our Camperini deadlift, because again, we do have 90 degrees available to us. We want to turn the spine. So I'm going to put a contralateral load on my Camperini deadlift towards the heels elevated side, and again, to turn the spine and the sacrum. If I want to go into a split squat activity, I can do that as well, but I'm going to elevate the front heel under these circumstances. So again, I want to maintain that yield as I move into that 90 degrees. If I need to promote more expansion, more yielding action, I can start to move you into a prone propulsive activity as well. Ultimately, what I want to be able to do is to recapture an eccentrically oriented pelvic outlet in deep hip flexion. So my ultimate resolution here is going to be a heels elevated deep squat with a band around the knees, but this is not pushing out into the band. This is maintaining an orientation of the femur so I can get the pelvis to move around the femur, and this is going to help me capture that eccentric orientation of the outlet in the bottom of the deep squat. And so basically we're at the top of the squat, we're going to take an inhale, we're going to exhale to mid-range where we would typically have the concentric orientation, and then I'm going to re-inhale to eccentrically orient the pelvic diaphragm as I sit down into that deep squat. Okay, so that covers the Hawkins Kennedy in the shoulder with the equivalent in the hip, the near in the shoulder with the equivalent in the hip, and so now we have to have a painful arc. And so under these circumstances, what we're going to use is the traditional hip abduction measure, also an external rotation measure. And so what we're going to see here is we're going to have a hip that has a lot of internal rotation and not a lot of external rotation, and we're going to see that limitation in hip abduction or external rotation, and we're going to get more of a lateral type of a discomfort. Where this is going to commonly show up is we're going to see people with the right oblique orientation of the pelvis. And so where we get the compressive strategy is here, and it's going to drive this left side up and over the right side. So this is our typical right oblique, and what we're going to see is we're going to see the impingement on this side. And so this is the inability to acquire a late propulsive strategy on that affected side. So from an interference standpoint, we want to avoid the bilateral symmetrical activities for a while, because what we have to do under these circumstances is take that right side and push back into the left to overcome the oblique axis. So we can start in left side lying with a right propulsive type of an activity. In this case, if we go into the gym, we're going to use our Camperini deadlift again with the heel elevated, but this time we're going to put an ipsilateral load on that heel elevated side, because what we want to do is we want to hold that back and push with the right foot, and that load's going to emphasize that right push. So again, we're turning back against the oblique. We can do a right foot forward, front foot elevated, right side loaded split squat. So this is about driving that late propulsive strategy on the right side all day, every day. Right suitcase carry is going to get us there. Go back to the video that we did about the suitcase carry. It was a week or so ago, and you'll see that we were talking about increasing max P on the opposing side, but we're going to take advantage of the ipsilateral side under these circumstances, where we would normally use like a cable chopping activity in the early phases of trying to recapture the turn of the spine. Under these circumstances, I'm going to use a cable lift because I'm trying to drive that right propulsive strategy, and it's much easier to do a cable lift under these circumstances and still capture the turn into the opposite side. A little bit of a finish kind of conditioning thing. Your right to left sled drag is going to be a nice way to finish, because again, we're just emphasizing that right propulsive strategy. So Chris, I hope that is helpful for you and for the rest of you. Remember, the shoulders and the hips are very much the same, so don't treat them any differently. Very, very useful in regards to your conformations and checks and balances in regards to range of motion, so use them accordingly.